presenting the case of Mrs. RB, 51 years old, female, resident of Manesar, Gurgaon, studied till 12th standard, homemaker by occupation. History is given by the patient and her husband and seems to be reliable. She presented with chief complaints of nausea and decreased appetite and generalized weakness for 3 to 4 months, fever for 3 days and right-sided abdominal pain for 1 day. Patient was apparently well till 2015 when she was diagnosed to have TB in brain, which was diagnosed on MRI brain and CSF studies. Patient had presented with the complaint of fever and persistent headache at that time, for which she took anti-tubercular drugs for 1.5 years. During that time, while undergoing routine investigations, she was told by the doctor to have few cysts in both the kidneys, and that the disease will progress with age and will require regular monitoring. As recalled by her husband, BP was normal at that. BP had been normal since that time, and kidney functions in blood tests were normal.
This was how many years back?
In 2015.
So 10 years back.
Yes, ma'am. At this time, patient was advised routine ultrasound and routine investigations of her family members, but she did not follow the same. Resolution of TB was confirmed on repeat MRI scan, and repeat CSF studies were also done at the end of the treatment. Since then, patient was on regular follow-up, 1 to 2 year follow-up with her doctor, same doctor, and regular kidney function tests were being done. She was diagnosed to have raised creatinine for the first time in 2017, which was around 2 to 2.5, and later on it increased to 3 to 3.5 in around year 2022 to 23. In year 23 to 24, she had raised serum creatinine of around 5. During this period, patient complained of on and off headache and was found to have newly diagnosed hypertension, which was well controlled on one antihypertensive.
When was this done? The headache, I mean the onset of hypertension?
During the period from 2022, she remembers roughly that she was diagnosed.
So you mean to say the hypertension happened after the renal failure?
Yes, ma'am. She gave a rough idea that around in 2017 her creatinine was raised, but BP she started to have since last 3 to 4 years only. There was no complaint of any episodes. There was no episode of pain, abdomen, or blood in urine. In view of rising creatinine, patient visited multiple doctors and was on alternative medications for last 1.5 years. Over the last 5 to 6 months, patient complained of generalized weakness, nausea, decreased appetite, early satiety, and abdominal fullness. She was advised dialysis initiation because her creatinine had now increased to 7 to 8 at this point of time, and but she did not follow that advice. There is no history of blood transfusion or requirement of any subcutaneous injections required to increase hemoglobin. There is no history of decreased urine output or swelling of both the feet. The patient now at this time presented to Medanta emergency room with complaint of fever for 3 days, high grade associated with chills, continuous, relieved on taking paracetamol. It was associated with history of pain abdomen in right flank for last 1 day, intermittent sharp shooting, not radiating, associated with nausea, 1 to 2 episodes of vomiting in last 1 day, which was non-projectile. There is no complaint of urgency, frequency, hesitancy while passing urine. There is no relation of pain with food, not associated with any passage of blood in urine. A patient was, during this admission, patient's creatinine was 9 and she was advised dialysis initiation. Patient underwent 1 session of hemodialysis via right-sided neckline, which she tolerated the hemodialysis session well, although had complaints of nausea and occasional headache. There is no history of blood transfusion during this admission. On past history, patient has history of brain TB in 2015, for which she took anti-tubercular drugs for 1.5 years. There is history of hysterectomy in 2022 for excessive uterine bleeding, on evaluation of which there was no malignancy. There is no history of diabetes. However, she has hypertension for last 3 to 4 years. On personal history, patient is non-alcoholic, non-smoker, consumes mixed diet and has normal sleep-wake cycle, normal bowel bladder movement. In family history, on tracing the family pedigree, there is history of kidney disease in mother who was advised dialysis. but the nature of kidney disease was not known. She had hypertension, but there is no history of diabetes. Her mother died at age of 65 years. She had sudden unconsciousness and was later on taken to hospital, where she was where she was found to be dead. Further tracing the family tree, there is no history. All the siblings of her mother were not evaluated. She has 2 other siblings, 2 sisters, of which one sister has kidney stone disease. The other one is still not evaluated. She has 3 children, 2 sons and 1 daughter. They have also not been screened as of yet.
What are the age of the children that you want to screen?
25, 27 and 29. She has 3 children.
What are you going to look for when you screen them, or what criteria are you going to use to screen them?
So first choice of screening will investigation of screening will be ultrasound. Modified Revines criteria we will.
Be careful. This is a history. This is a patient who has a history of polycystic kidney disease.
Yes, ma'am.
So what criteria we will use?
In a patient with known history of known positive family history of ADPKD, we will do ultrasound screening based on that Modified Revines criteria. We will screen them.
What is he saying? You said one is 18 years, the other is 25 years.
One is 25, one is 27, and another is 29.
29. 3. So in all these 3, how will you know on your ultrasound basis who has polycystic kidney disease, who doesn't have?
At least more than 2 cysts should be there in according to the Modified Revines criteria. More than 2 cysts.
In a person with polycystic kidney disease, does it change?
Sorry, ma'am.
In a person who has a positive polycystic, I mean a history of polycystic kidney disease, you still need 2 cysts to define between 20 and 40 years?
Total of 2 cysts, yes, ma'am.
Total of 2 cysts, or only 1 will be enough? And what cyst?
Total of 2 cysts in both the kidneys, according to the modified criteria that says. In patients with positive family history, in modified criteria, they have said more than 2 total cysts for diagnosis of.
What are the criteria?
Age group of 15 to 30, then between the age group of 30 to 60, more than 2 cysts in each kidney.
They are modified now in saying 15 to 30, 30 to 40, 40 to 60, more than 60.
But both of them they say ki more than 2 in each kidney, 30
in 30 years of age?
30 to 49 and then 50 to 60.
So all of them have to have more than 2 cysts?
More than 2, 15 to 30 it is more than 2 total cysts. 30 to 49 and 50 to 60 it is more than 2 cysts in each kidney. Then more than 60 it is more than 4 cysts in each kidney. The only difference between the age group that they have split is because of the positive predictive value and negative predictive value that was changing between the 2 age groups. But otherwise the criteria that they have mentioned to be diagnosed is that only more than 2 cysts in each kidney.
That is for a diagnosis. But if you have a family of polycystic kidney disease, you don't need to have so many cysts. Have you gone through that? That's a MRI criteria to exclude polycystic kidney disease, not to diagnose polycystic kidney disease. This person, what would you want? You want to exclude them.
Yes.
Why? Because if this lady needs to have a transplant, will you be taking their siblings? There it's more than important is that they don't have polycystic rather than they have polycystic kidney disease. There are 2 different, there are textbooks which will tell you this. That criteria you said, no, more than 64 cysts in each kidney, 40 to 60, 2 cysts in each kidney. Less than that, it is actually 2 cysts.
Yes,
1 or 2 cysts, either unilateral or bilateral, isn't it?
Yes, ma'am.
Are you sure? But then if you have a polycystic history disease, wo dekho usme kya. And what should be the cyst size? Any cyst?
Ma'am, this time the KDIGO 2024 guidelines, they have written this table only.
No, what cyst size?
Criteria.
Very microscopic, 5 centimeter cyst, 1 centimeter cyst. Whom will you tell a cyst? That is also important, no? The cyst size, you have to, number of cysts when you say, what is the size that we say that this is a cyst? But that's not the issue for them. He asked for a screening.
Yes, ma'am.
What you mentioned is, like ma'am said, for the general population as a screening tool based on ultrasound. And for somebody with positive family history, like if you are evaluating a close family member for transplant workup, then you need an MRI. And like ma'am said, you need to make sure there's not
Yes.
even one cyst present.
Yes.
The down part of modified revines is you can miss PKD too because the cysts appear at later ages.
Right.
So they've made out another PIES criteria that you can use, that is 15 to 40 and then 40 to 60
40
and
to
more than
60.
60. So that's more like a screening tool for the general population.
What you said was for diagnosis, but to exclude that you need an MRI. Ultrasound will not help you.
Okay.
You understand?
Okay, ma'am.
And as is, even more than one cyst is a diagnosis.
Yes.
Clinically, if you were to evaluate one of our sisters who we think does not have PKD yet or something, you do an MRI, even if it is like showing one cyst or a borderline thing, you can even do genetic testing to add on to make sure that you're not missing a PKD here potentially.
You understand?
Yes, ma'am.
That person, the sister, we are trying to look into even a single cyst, you will be much more suspicious, get into your genetic testing. So now in this case, what do you think is not fitting in with your history? What is the natural history of polycystic kidney disease?
Usually by the age of 40, a patient should be developing
No,
should
that
be
again
having
is it
hypertension.
PKD1, PKD2 are two different things, no?
Yes, ma'am. And should
So
be
how does
having
it start? Does it start with renal failure, hypertension, or hypertension, renal failure?
Initially hypertension and then kidney dysfunction starts later on.
But your patient is different. Why
Yes,
is this patient
ma'am.
different?
Maybe
What do you think? What do you think has you said that the renal failure started before? No?
2017, yes, as per the history, yes, ma'am. Could be that patient, the diagnosis or reporting of hypertension must have been missed.
Missed by this patient. What all would you have asked to find out? What did the patient have? How does the polycystic kidney disease behave? Creatinine is the last stage of. I'm sure if you understand polycystic
Yes,
kidney
ma'am.
disease after renal failure behaves very badly, isn't it?
Yes, ma'am.
Especially PKD1. What else history would you have taken for this patient?
Apart from hypertension and then symptoms of early satiety, abdominal
That is,
fullness.
you are looking at polycystic, but somebody with renal failure, edemas, nocturia, frothuria, don't you want to say you just focused yourself with a person with polycystic kidney disease? You just told us that this is the renal function, and I am an examiner, I am very, very allergic to creatinine. You have to say progressively worsening. And then you have to look for uremic symptoms and all the symptoms that you are saying, we don't know whether it's cyst infection or uremic symptoms, that also you have to separate. We had never got the history, did the patient develop edema or not? Was there a history of any inkling of a proteinuria? Polycystic kidney disease can coexist with other diseases also,
Yes, ma'am.
isn't it?
There was-
Not necessarily she had only. Then she had a tuberculosis treatment. Was there any renal failure secondary to ATT or something? She took 1.5 years of ATT, isn't it? Headache. And I think he and I would be very interested to know when the TB brain was diagnosed, was there anything else looked into the brain at that time?
Yes, ma'am. I asked.
Did you ask specifically for that?
Yes, ma'am. I
Because that's
asked
very important for us to, because you gave a history that mother became unconscious and declared dead. Isn't it?
Yes,
So
ma'am.
did you ask?
Yes, ma'am. I specifically asked about any involvement of vessels, any swelling of the vessels in the brain during that time, if she was reported to have any, or but he did not have any available reports. But he said that no such abnormality was reported other than the TB part.
And what did they say the headache was? Because you have more headache now. And how did they make a diagnosis of TBM? I mean TBM or whatever, TB brain you said.
Retrospectively, what I asked from him, from her husband, was the CSF studies. They said some fluid was
Why
taken
don't
out
they
from.
redo CSF just like that? Something must have been the clinical presentation, no?
She had fever and headache at that time that I told, yes ma'am. Fever and headache she had at that time.
Don't mind, you probably know this is a patient with PKD. When you're telling the story, to be honest, I did not get any clear evidence
never
so
got an-
far
yeah.
that why are we talking about polycystic
PKD.
kidney disease
And a
here?
history, yes.
Why is like the story you come up with? We don't know anything about this patient. I've not seen the CT scan or ultrasound of this patient. The story you are telling is could be a patient with
It's
normal
just a chronic
CKD.
kidney disease who has come to uremia and is
And
getting
like
dialyzed.
so many CKD patients have cysts on their kidneys. Does that make them a polycystic kidney disease? No. So I think when you're narrating your story, you gotta give up like some evidence so far, like why was this diagnosis made or what was done. You focused on the essential parts, but the story doesn't bring out this is a case of PKD.
See, 10 years back, that's why we asked. She's 51. She was 41.
41.
And at that time, she was told that she has some cysts in the kidney and needs familiarly. Then you have to know what are the kind of cysts. We have developmental cysts.
Yes,
We have genetic cysts, congenital cysts. Then we have developmental, genetic, acquired, cysts with neoplasms, cysts with systemic diseases.
Right, ma'am.
Isn't it each one? And we never got a clue that this is the, let's say, a developmental polycystic kidney disease, isn't it?
Ma'am, throughout the course, since
Throughout the course, we got to know that this is a patient who had renal failure, now has come with uremic symptoms and has been started on dialysis, and we are looking for a family history.
Yes, ma'am.
That's it.
Yes, ma'am. So from 2014 to 2025 till this time, she had some cystic disease along with some kidney disease with progression. Only until now, when we are having the family history of her mother, that we are suspecting that it could be autosomal dominant polycystic kidney disease.
Are you aware of something called autosomal dominant tubulointerstitial kidney diseases?
Could also be there. Yes, ma'am.
They also progress slowly. They may not have any of these manifestations. I think in India that's also common. So you have to give us an idea. See, from your point of view, we would like to know what is this kidney disease. Is this a kidney disease which is proteinuric? Or you have given a very strong history that there is no blood transfusion.
Yes, ma'am.
You understand? So it tells me that this is something else is happening. Why is it that you come to, many times you mentioned that there was no
Blood
transfusion.
During this
Is that common? Is that common in which kidney disease? Everything comes in our mind. You have to present it like a way that we need to, as Sagar was saying, none of us got, both of us did not get exams, we will not know. We will be, when the student comes, none of us know. You have to present in such a way that we get a clue ki what are we dealing with. You understand?
Why did you specifically say twice no history of PRBC transfusion?
So before that, when I was narrating story from 2014 to 2024, telling the progression, there was no episode of hematuria, blood in urine, or any blood transfusions requirement, edema. I was talking about normally about the CKD progression, how it would have behaved. And during this episode,
No edema. Is polycystic kidney disease no edema state or a dry state, or how do you? Anyway, then let's not
patient
get
can
into
have edema if over the course of period she
They will
becomes
develop edema,
oliguric or
they become proteinuric, no?
Proteinuric also.
That's why we think of treat the hypertension, treat the proteinuria aggressively in them.
Yes,
Is it?
And during this episode, I again mentioned about this admission. I again mentioned about blood transfusion because she had pain abdomen. So and
Estably, hematuria is so gross that you need to transfuse these patients in our renal failure. Was the blood transfusion told to us to indicate that it was not a significant hematuria, or told to us because that she didn't have anemia?
She could be having cyst hemorrhage, which could be present with anemia and then requiring blood transfusion. So,
What year are you?
so final year.
Finally.
Just honestly asking, how many like PKD patients have you seen actually? This
So
is not like a
many.
grilling question, I'm not being
Many
rough here.
patients.
Many patients. So they have hematuria very often, and it is like ma'am said, I didn't get the clue from what you said. No transfusion history means no hematuria or severe hematuria. That doesn't really go like, one and one. That is not the usual case. They will have hematuria episodes off and on. Cyst hemorrhage, cyst rupture. They can have hematuria lasting anywhere from 3 to 7 to even 10 days, and yet they may not need a blood transfusion.
So when you're saying that hematuria and blood transfusion does not link, I don't think even in our clinical practices we have seen any massive hematuria requiring blood transfusion with chronic kidney disease. Stone disease, urologists may have some bleed beat, they may need blood. In our patients, when do you hematuria clear blood transfusions? And this is also, you said no hematuria, no? Never had hematuria.
Yes, ma'am. Never had.
Is there a pathophysiological relation between what you just said, PRBC transfusion and PKD, if I ask you that question?
Yeah.
Leave apart hematuria, you mentioned twice, PRBC transfusion, and I'm asking, is there a pathophysiological, anything, any connection between PKD and anemia? Or
we are concerned if that she has not received transfusion. And why so? That's the only thing.
To reframe the question, anemia and polycystic kidney disease, we are assuming this is the ADPKD patient. Anemia and ADPKD, what comes to your mind?
Sir, anemia and ADPKD could mean, first of all, patients of ADPKD are less likely to be anemic. So if
Why?
Why?
Because of multiple cysts having local hypoxia and releasing in return, in view of activation of hypoxia inducible factor, there is a release of erythropoietin, and that is why these patients do not have anemia.
So yes, you're theoretically right, like EPO levels could almost be double of normal CKD levels compared to other etiology of CKD diseases. But I think clinically we don't see that too common. They're still gonna need EPO and arbivortin, whatever the stage is.
EPO levels are double that what you see in CKD patients, but still not enough to maintain your hemoglobin levels. So anemia is also common. I'll put it across. Still, what is the other problem when you see this patient is not anemic? What concerns will you have? What are the other things that you see where erythropoietin production is more? You said kidney. Where else the erythropoietin production happens in ADPKD?
Could be conversion to some form of carcinoma, RCC.
One, and somewhere else erythropoietin production is in. Where is
Liver
erythropoietin
also.
produced? Liver.
Yes.
Does that make sense? Isn't it? Okay, now ask some questions again.
Move on with the case present.
Now, what is your summary of this case? Summarize this case.
50 years old female with a known case of hypertension for last 3 to 4 years and some form of cystic disease diagnosed at the age of 40 years, now presented with rising creatinine. That is, and I would like to keep my diagnosis of chronic kidney disease with progression, likely secondary to.
This is dialysis, chronic kidney disease stage 5D. You have already said.
Now initiated
Isn't it?
in this, yes. Secondary to likely autosomal dominant polycystic kidney disease, considering the positive family history of the patient, now presenting with.
Family history, you got renal failure and consciousness. You never got a family history of cystic disease.
Yes.
Mother dying at 65 with hypertension is very non-specific.
I know. So if you want to really say, you should see the first thing you will get is a syndromic diagnosis. And there are only 5, 6, 7 syndromes in nephrology. One of them is the chronic kidney disease stage 5D.
Yes, ma'am.
Stage 5 initiated on dialysis. That's accepted. Then you come down to a etiological diagnosis. In that also you should again try to use cystic disease. Go to polycystic kidney disease when you are absolutely confident.
Okay.
Most probably some form an inherited cystic disease. Leave it open like that. No?
Okay.
And let the examiner ask you for reports and investigations and take it forward. No?
Yes, ma'am.
Inherited cystic disease. Then comes the complications. You don't have anemia. You don't know bone diseases. All this you know. We don't have any history of this. And then the third complicate, possibly a cyst infection by acute pyelonephritis, because you're still not sure what is happening.
Right, ma'am.
Isn't it?
Yes.
She could very well have like an acute kidney injury component
Yes.
because of the pyelonephritis. That AKI stage 3 on CKD, that needed some dialysis in the beginning, but there is a small chance that it might even turn around. So I think you should mention that in the case summary too, like ma'am said. Make sure you include that part also.
Always look into a point, because it's sort of everything. Creatinine, don't say anything. Progressive worsening, came with nausea, vomiting, then now initiated on dialysis. There could be an AKI component into it. No? The AKI component could be your intravascular volume depletion because she vomited, or it could be even an infection.
Ma'am, but she mentioned that around last 5-6 months, her creatinine was around 7 to 8, and she was advised initiation of
Still,
dialysis.
it's no harm in
Doesn't
saying
matter.
that there is
Acute.
Always.
Possible.
Never harm. She may be 7. She may just get out of dialysis if you make her better. Always keep that in your mind. Don't give up. Try to find out what is happening.
Yes,
This is not about the exam. Even when you go into practice
Clinical
next
practice,
year,
yeah.
you have to keep these things in mind. Like somebody's coming to you, always see like you don't want to miss something. That would be the wiser thing to do. Anybody can, like, everybody here in the room knows, okay, you have to dialyze someone with 9 creatinine uremia, but you still have to keep something at the back of
Is
your
there a
mind.
reversibility in this?
Yes, ma'am.
One. And the second thing, as he was saying also, there was an element of, you said, native medication use also.
Yes, ma'am. Alternative.
She was still on alternative medicine. Abhi, till now?
Till now, she was
Only on alternative.
Yes.
She is
for
not.
1.5 years.
Oh, okay.
And single antihypertensive she was also taking.
So there is always a question of, as he said, we would look for reversibility because she is on alternative, blood pressure uncontrolled, with a element of, you are saying cyst infection. How do we know cyst infection? We don't even know the size of the cysts. Your examination will help us with some more, and then. Okay, now can you tell us the examination
Yes,
findings?
ma'am. I examined the patient on day 2 of admission. On examination, patient is alert, conscious, cooperative. Her weight is 60 kg, height is 162 centimeter, and BMI was 22.8 kilogram per meter square. She was examined in lying down position. Her pulse rate was 82 per minute, regular, good volume, no radial or radiofemoral delay.
Do we need to do all these things?
Special corrective.
Itna nahi bola. Radiofemoral makes no sense. You will go into a situation when we'll start asking you what are the link between radiofemoral delay and polycystic kidney disease. Can you think of something? Radiofemoral delay and polycystic kidney?
No, ma'am.
Dissection of the aorta. So don't get into all those. Don't ask for things which a nephrologist don't want to listen to. Pulse is good, volume. Yes, you may, if you think of aortic regurgitation, you may say something about the pulse. Isn't it?
Yes, ma'am.
You have to have an idea why you are asking, and then we are some very cranky examiners. We'll get you into radiofemoral delay causes, not into, you will forget that you will come here for a polycystic kidney. Make it simple.
Yes, ma'am.
And I don't think you even check radiofemoral delays nowadays. Any one of you checked ever radiofemoral delay nowadays? No.
Uncontrolled. Blood pressure was 150/100 in right brachial artery in lying down position. There was no pallor, icterus, cyanosis, clubbing, pedal edema or lymphadenopathy. JVP was not traced. On urine dipstick examination, protein was 2+, RBCs negative, and leukocyte esterase was 2+. Glucose is absent. On per abdomen examination, umbilicus is central, bilateral flanks are full. On palpation, abdomen is soft. There is right flank tenderness. Bilateral kidneys are palpable and ballotable. Shifting dullness is absent and bowel sounds heard normally. On cardiovascular examination, apex beat apical.
Can you do shifting dullness with large kidneys? Clinically?
Ma'am, we can trace not completely to the lateral
So
side.
then
but
don't get into those kind of things. No? Very difficult to do. How do you do shifting dullness with somebody who has got huge kidneys? Isn't it? That just means that when you shift, the dullness shifts. You shift the patient, the kidney is still there, no?
Yes, ma'am.
It's just the water which is moved. So don't say shifting dullness like that. Why did you want to look for shifting dullness in this patient?
Ma'am, if although less likely, but patient can have ascites as part of
They can still have
volume
it, no?
overload, and maybe because of other system involvement also. In that case, liver involvement.
How common is liver involvement in polycystic kidney disease? Autosomal. Again the same, how many ADPKDs have you seen with jaundice? Or portal hypertension?
None, ma'am.
Have you?
No, ma'am. Synthetic function largely remains intact.
Yeah, you're going to see a lot of liver cysts in these patients, but
Huge
most
cysts,
of them, they do not lead on to liver failure
Yes,
per
sir.
se.
Yes.
And volume overload is more important with ascites or with
pedal
pleural
edema.
effusion, pedal edema?
So that is why it is, yes ma'am, it is less likely. On cardiovascular examination, apical impulse is seen in fifth intercostal space on left side. On S1, S2 is normal, no murmur heard. On respiratory examination, trachea is central, bilateral chest movement equal on both the sides. On auscultation, normal vesicular breath sounds on each side. And
I would ask you during examination, no? Respiratory system examination is essentially normal except for these findings. Same, cardiovascular system essentially normal except for these significant findings. You get away with the examiners because the moment you said fifth intercostal, I'll ask, where is the LVH there? Have you looked into cardiomegaly and things like that, isn't it?
on
Which
CNS
will have an impact on your history of hypertension.
Yes.
Which is either ways not fitting into your normal story.
History. So try to not to say more than what is necessary. Never. You are not come to, you are a super specialist. You are not come to impress us with your clinically. Just you are come to us with discuss a case, form your opinion and share it with us. He's very trouble. You will get into trouble moment you said fifth intercostal space. Isn't it? So then the question again, we go back to that hypertension का क्या हुआ, कब नहीं हुआ, miss किया, kidney खराब हो गया but hypertension. How many patients of renal failure have normal hypertension? You tell me, what percentage? Have you ever thought of this? This is a question we'll ask everyone. What percentage of chronic kidney disease patients have hypertension and how much it improves after transplant? These are basic clinical questions, no? This will be asked in your presentation. Thinking? No, I have troubled them quite a bit.
Never. Good. So, but summarizing, any pertinent positive findings? You mentioned no pallor so far. And no signs of volume overload either.
No, sir.
No edema, no ascites, whatever it is, hard to
big
find.
palatable kidneys.
Big palatable kidneys. That's it so far, right? Anything else? And flank tenderness, right flank. What else? Any pertinent positive that we should know?
In the abdomen, anything else? Hernias are very common in these people. You should ask for hernias or something. And you are saying it's a infection. Did you look for renal angle tenderness or anything of that? Boys, was those kidneys tender anywhere? Because that's the first sign of your infection that you're going to see, no? Cyst infection. Whether tender?
Right.
When you palpated, did you see any place of tenderness?
Yes, ma'am. There was tenderness in right flank.
Right flank. ठीक है. Right flank means where? The kidney moves, your kidney is from hypochondriac to the lumbar region almost, isn't it? So which part of the kidney, which kidney did when you palpated you thought was tender?
Ma'am, it was a different...
Right flank tells you there is a liver disease or something, cholecystitis or something, no? So you have to be extremely careful when you have two kidneys, which part of the 9 segments of your abdomen is you felt the tenderness on the kidney? Or was it something else that was causing the tenderness? Could you really tell us that this was the kidney which was tender? Because you are making a diagnosis of cyst infection, isn't it? You said patient had fever, isn't it? Clinically, just do clinical, no theoretically. Just tell us clinically what you think, isn't it? Summarize, as he says. Anything else would you like to discuss? Edema bola tha?
She said, no. I thought she said no edema.
No edema, ma'am.
Yeah.
Something we always ask some of us, do you know the skin changes of chronic kidney disease which you can look into?
Ma'am, first of all, dryness of skin. There will be xerosis and scratch
Did you ask
marks.
of history for pruritus or something like this? itching का history लिया था पहले. Did you ask? That helps us a lot because it says it's a long-standing chronic kidney disease or somebody who's chronic and got into an acute form. Nocturia, you didn't tell us. Did you take a history of nocturia?
Nocturia was not there. I have
Not
written
there.
also. Yes.
That again is.
बिल्कुल. Well, also, like, if it was me and trying to paint a picture of PKD, I would tell the negative symptoms. You know, just ask the early satiety, abdominal fullness, dragging sensation, chronic pains, flank and back. These are all part of your PKD symptomatology, right?
Yes, sir.
Because you're telling us she's already CKD 5 with PKD. Suppose I'm saying this is the case we're dealing with, then you should give the symptoms. You can focus a little more on the negative signs and symptoms of that disease also.
Dragging pain is very common. When you sit, they have a very strong, like those pregnant mother kind of symptoms.
That she had symptoms of early satiety and abdominal fullness, but no pain.
No dragging pain,
Yes,
no
ma'am,
other
I
pains.
mentioned.
And then PKD patients have a concentrating defect. So like ma'am said, you know, nocturia, polydipsia, those things will also be kind of relevant.
Very important. Polydipsia, thirst, nocturia, polyuria.
Polyuria.
They have a concentrating defect, no?
Yes, ma'am.
Then, so this is it. So after this, what are the anybody carries the investigation from Medanta or
Nobody.
you are alone?
Yes, ma'am.
So you got the, what are the investigations you want to get?
Ma'am, first of all, CBC, complete blood count.
Tell some of the investigations and then.
Do you have the investigation details of this patient with
Yes, sir.
you? Okay. So what all did you do?
Complete blood count was done. HB was 11 and TLC was 13,500. Neutrophils 95%. Platelet count is 213. Then kidney function tests of the patient. She had blood urea of 112, creatinine 9.1, serum sodium 135 and potassium of 5.3. Then phosphorus was 7.9, calcium 7.2. PTH was 240. Urine routine microscopy showed pus cells of 10 to 12 per high power field. Protein was 2 plus. Then RBCs 3 to 4 per high power field. And then only ultrasound was done as of now until I examined the patient. Both the kidneys were enlarged. Should I mention? Both the kidneys were enlarged in size, show numerous anechoic cysts scattered throughout renal cortex and medulla, distorting the renal architecture. Largest cyst measuring 4.4 into 4.5 mm at upper pole of right kidney.
4.4 to 4.5 mm or centimeters?
Mm.
Mm कैसे देख रहे हो इतना छोटा सा cyst? Less than a centimeter cyst you're saying?
That's what.
And that is the largest.
That's the largest. I think you have to look into it properly.
I think centimeter only.
Then I will say this is an ARPKD kidney who's grown up to till this age.
It's
The largest of the cysts
centimeter
being 4-5 mm.
Or ADPKD, autosomal tubular interstitial kidney disease. Isn't it? Even earlier days we used to use the word medullary cystic kidney disease, which is now named into ADPKD. Isn't it? So,
Any first year there?
any first years? हमारे दोनों बच्चे हैं.
Which ones, huh?
Those who बैठे.
What do you look for in the ultrasound, Doctor? AKI versus CKD. She started to read out the ultrasound. Normal कोई patient आया, 5 creatinine के साथ आपके OPD में आया है. आपने ultrasound लिखा. What are you looking for? You did not mention the kidney size.
Kidney
This is
size.
enlarged, but kidney size.
Right kidney is 13.8 centimeter, left is 12.8 centimeter. 13.8 into 6.5.
There's so many things in your case that don't even fit
In with
ADPKD.
See, you please understand, this does not fit in with ADPKD. Somebody who's 10 years back has been told that you have a cystic kidney disease. Natural history of polycystic kidney disease will not behave like this. Can you look into 12 centimeter is hardly anything. A diabetic kidney looks like 12 centimeter.
12 and a half, 13 is nothing. When you've seen enough patients, you'll see 16, 17, 18, 20, 22 centimeters. The kidneys are like this huge, they are occupying the entire retroperitoneum. Sometimes there's not enough space, they're pushing everything in the front. And if you have to do a transplant,
bowel loops you cannot see.
yeah. If you have to do a transplant, you'll have to remove the kidney to make some space to put in a new kidney.
Yes, sir.
This is, you know how much from the lower rib to the pelvic? 25 centimeters. तुम्हारा 13 है. वो kidney तुमने palatable भी कैसे देखा? I wouldn't have even palpated the kidney.
12.5 is very hard to palpate, and I wouldn't even call it pilotable.
Please understand, we are clinicians here.
Yes,
We are prepared to look for out of the ordinary. Making a single diagnosis, you have got this, your mind should immediately say, this is not how a polycystic kidney behaves. That's why he asked size. Then could you see any cortical parenchyma? Nothing you could see. This is completely distorted.
Yes, ma'am.
Huh? Nothing, no? तो कौन से cyst में infection देख रहे थे आप? Then put ultrasound report after that.
One sec. So, I think you
Next.
should complete. You're doing fine. Size is number one. So, CKD size will decrease. Other than
Which diseases the kidney size will not decrease?
the creatinine is 5. I'm telling you this is CKD, but the kidney size is normal. What comes to your mind?
Any one of you? Diabetic kidney
Diabetic kidney disease, because that is probably
amyloidosis.
anything with an infiltrating disorder.
Sarcoid or
Sarcoid,
whatever.
amyloid, or diabetic kidney. The reason why this is important, in normal practice, nobody is getting a regular KFT done in the outside population. You're going to have a patient walk into you with a creat of 7, and then it is your call to decide what's going on here. They'll tell you, oh, I'm diabetic for 1 year or 2 years. So do you biopsy them? Do you look for further testing, or what do you do? So size you mentioned. Second, cortical echogenicity. That will also tell you between what is CMD. So what is cortical echogenicity? How do you look for it? Now a lot of focus is on POCUS. So suppose I give you the ultrasound probe, how will you know what
That
is
this
the echogenicity?
is a normal echogenicity or increased echogenicity.
Exactly.
Echogenicity with the liver.
So assuming the patient does not have a liver disorder, you look at the echogenicity of the kidney and compare it to the liver. If it is more increased, like it is whitish or it is more echogenic, then you will call it a raised cortical echogenicity. And then the third thing you mentioned, corticomedullary differentiation. So those are typically the 3 things you look at. Just I'm saying AKI versus CKD. Of course, you're looking for 10 other things on an ultrasound. So I think in your case, a lot of things are not fitting in, ma'am. The size of 12.5 and 13 leading to a CKD 5 status is not impressive. The largest cyst of 4-5 mm here is not impressive. The timeline.
4-5 mm, so I can't even. Do you know this much?
Yes, ma'am.
Which college 9 centimeter kidney, 12 centimeter में बड़े-बड़े cyst हो जाते हैं. Next, follow, and then so this is your ultrasound. Anything else in the ultrasound you would like to say?
Ma'am, liver also had no cyst.
So then echogenicity, any echogenic foci, stones, calculi,
No hydronephrosis, nothing. Yes, ma'am.
no hydronephrosis, no anything else that will help us. Any other thing in that kidney you could not. So then next.
What you said about hydronephrosis, even with a proximal ureteric stone, you may not see hydronephrosis in PKD patients.
patients.
There are a lot of parapelvic cysts sitting, which may not allow the pelvis to expand and look hydronephrotic like a normal kidney.
Yes, sir.
So
Hydronephrosis, that means, I mean, that's why a CT scan for this. Then next.
Ma'am, CT was planned for the patient yet, but it was not done.
No, any other investigations?
These many only.
So you have a patient who has 10 to 12 pus cells, 3 to 4 RBCs and 2 plus protein with a creatinine of 9, 12 to 13 centimeters of kidney. Would you like to revise your diagnosis?
Yes, ma'am.
Would you say this is autosomal dominant polycystic kidney disease?
No, ma'am.
नहीं हम लोग बोल रहे हैं उसने ही मत बोलो. You think of.
No, ma'am, no. It will not be a diagnosis of autosomal polycystic.
So then how are you going to, anything in the biochemistry that you will go back and look now? What? Calcium was okay, PTH भी बड़ा नहीं हुआ था.
154.
200 something.
240.
So that's again the question of an AKI happening. Did you look at the uric acid?
Ma'am,
How much was the uric acid?
did not mention here.
That's another thing you look back again, no? Hyperuricemia, ADPKD. Now, what do you think is worsening? Are you going to just dialyze the patient, and what are your plans after this?
Ma'am, I would like to keep after the investigations. I would like to keep my.
No, what are the other investigations would you like to do now?
Yes, ma'am. On the suspicion of acute on chronic kidney disease with acute pyelonephritis, query acute pyelonephritis, I would like to go forward with urine culture, blood cultures, and some
Blood culture because she was having fever also?
Yes, ma'am. CT scan to look for any perinephric fat stranding, along with. And apart from that, urine albumin creatinine ratio to document proteinuria, HbA1c to see if she is diabetic, although she does not give any history.
Will that matter now, HbA1c for diabetic now?
No, ma'am. At least not for the diagnosis of chronic kidney disease.
Her blood pressure was 190/100 you said, isn't it?
150/100.
What antihypertensive she is on?
She was taking amlodipine 10 milligram
That's
once
it.
a
And
day.
with that she was... So now how are you going to... You have started dialysis. The hemoglobins are fine. PTH is okay. You just have a mild hyperphosphatemia. Calcium is fine, isn't it? How are you going to go to your what are your things that you're going to look for in the diagnosis now? Will you call the sister and check her for investigation now? The sister who's supposed to have some cyst or something you said?
Yes, ma'am. And also genetic diagnosis we can, with the history of...
No, how are you going to manage this case now? First, start dialysis, manage dialysis and then treat infection after that?
And look for any renal recovery if at all. Also, once the infection settles, maybe we can consider doing biopsy.
Are you sure there is an infection in this patient? How do you prove infections in urinary tract? I mean, what are the diagnostic criteria for urinary tract infection?
Ma'am, fever, then pyuria.
Is it? How do you, what is the, you know, what is the Haas's criteria for UTI? Two things you need. Read up, and this patient, and then another thing, I don't know if you should ask, leukocyte esterase means infection, or you want to look into something more in the urine, in your dipstick?
Ma'am, nitrite also.
Nitrite, no?
That is
What
more
does
specific.
nitrite tell you? That there are
Bacteria.
nitrate reducing bacteria.
Enterobacteria.
And then they can tell you leukocyte esterase is that there are leukocytes in the urine. Isn't it?
You just mentioned biopsy. That's a very tricky thing to say in the exam. Like, I don't know, like I don't think of biopsying such a cystic patient ever.
Biopsy bolte, they will all jump on you. You have to now get into a
Like,
Now tell us one by one, what are the cysts that you know? Then we can, one by one, we said no, developmental. What are those cysts? Are you aware of developmental cysts?
Yes, ma'am.
What are they? Cystic dysplastic kidney.
Medullary sponge kidney and cystic
Medullary sponge kidney.
Yes.
Do you think there's MSK? Medullary sponge?
No, ma'am.
Why?
Ma'am,
One negative
first of all,
criteria
according
for
to the
her.
history, BP and kidney functions, they would be
They usually
normal,
don't go into
usually.
renal failure.
Yes, ma'am.
Medullary sponge may have all kinds of UTI, stones and all. They
Stones
don't.
and-
Next, your genetic. What are the ones you are aware of?
For autosomal dominant, it is autosomal dominant.
You have an ultrasound. Did you look into the liver? What did the liver say?
Liver
she
had
mentioned
no
no
cysts.
cysts.
Yes.
Didn't see. Now tell me, which organ does not have cyst in ADPKD? One organ. Are you aware? This is a question we always ask. Cyst can happen in arachnoid, everywhere, testis, epididymis, pancreas, liver. But one
Ovary-
organ, ovaries don't have. So if you have a lady with something happening in the ovary, don't say that's a ovarian cyst. So in this patient, did you look for abdominal pain, flank pain with a 13 centimeter? She can even have she's 51 years. So there was no pelvic organ abnormality.
Ma'am,
She underwent a
She
hysterectomy.
underwent hysterectomy.
But ovariectomy? That you
Ovari-
did not mention, no?
Ma'am, it was
Always,
not-
this is a clinical examination we are having. Abdominal, could be abdominal pain for anything else also. Next, ARPKD. What are the forms of ARPKD you know of? Do you think this can be autosomal recessive polycystic kidney disease?
Ma'am,
No, we have to now
very-
one by one think of it.
Yes, ma'am. Very less likely, but some cases
Less
can
likely.
present
Why do you
in
think it's less
adult.
likely?
Because most of them they present either in utero or in early childhood.
Even adult, but they have hepatic fibrosis.
Hepatic
Liver is a
features are
predominant.
more prominent.
By this age, they would have been either dead or they would have been completely liver
Yes,
gone, isn't it?
ma'am.
Next is what? Tubular sclerosis, von Hippel-Lindau.
No, ma'am, because other skin features present in tuberous sclerosis, they are not present.
Headache, she's complaining, no?
Yes, ma'am.
So that you should have, now you have to now go back and think of other things. They have headache, she could have a brain tumor, then you have to look for all those ash leaf macules and adenoma sebaceum. Only, I'm just saying. Then after this, VHL you think it is not there, isn't it?
Yes, ma'am.
Now then again, do you think it's an acquired cystic kidney disease in renal failure, long-standing renal failure?
But
What is acquired
cysts
cystic kidney
appeared
disease?
first and then kidney function
So
was
that's
later
not
on,
there,
so less likely.
isn't it? Do you think it's a neoplastic cyst we are missing? Any malignancies which can be here? No, no.
No, ma'am.
So then how do we now go back and diagnose for your biopsy to nahi karenge, that is for 100%.
Multiple
Yeah,
cysts,
biopsy in cystic kidney disease is very tricky. I've not
We
done
will-
ma'am,
no,
like,
no.
never. Yeah, there's not enough parenchyma. You know how much what kind of needle do you use in your institute?
Sir,
An automatic biopsy gun,
yes, sir.
which cuts out
Kitna
the
length
core.
hai? Core. Have you thought of it? Now what's the core?
What is the length of the throw when you're putting in your kidney? You see the kidney on the ultrasound. You place your needle at the tip at the surface of the kidney, right?
Cuts and comes out.
And then like the throw goes in and it cuts and comes out. So what do you think is the length of
the
that throw?
2 centimeters.
Yes, anywhere from 1.5 to 2 centimeters, depending on the make of
You
the
open
gun.
and see, you can make out the gun itself. It's 2 centimeters.
Yes, ma'am.
You are not gonna have a clear enough parenchyma in such a patient to do a biopsy.
Biopsy of 2
So saying a biopsy should like be
In multiple cysts in a kidney.
totally like it's a very tricky thing to say. Even if you have 2+ proteinuria, like ma'am saying, you have to go back to your cystic disease differential.
So how are you going to go for this? If this patient has money, what will you do now? You'll do genetic testing. So what genetic testing you will ask for?
Ma'am, since there is...
What genetic testing? I'm not asking the genes. That's anything.
Ma'am, since there is a discrepancy between our findings...
So that we
and
know. So
the
what kind of a
history,
genetic testing will you ask for?
whole genome sequencing in this case.
ठीक है, whole genome will get you what? Whole genome or
Whole exome.
exome?
Whole exome.
What's the difference between whole exome and whole genome and all those things?
Ma'am, whole exome...
ठीक है, we can discuss. You ask some other basics.
What are the mutations you were looking for?
In this patient?
Regarding ADPKD, it is PKD1 and PKD2. Those are the major genes. Then there could be minor genes when
Which chromosomes? PKD1?
PKD1 is chromosome 16 and PKD2 is chromosome
All of them you
4.
should say short arm or long arm of the chromosome, isn't it?
16 to
And 16.
21 and 4.
16 overlaps with what another cystic disease? PKD2?
PKD1 and PKD2.
PKD2 mutations overlap with another cystic disease.
And PKD1 overlaps
Two
with tuberous sclerosis.
Two overlaps with tuberous sclerosis.
Which chromosome was the PKD2 gene on?
Chromosome 4.
No,
4.
no, that's 4.
One
no,
is
one
16,
is 16, other is 4.
2 is 4, yes.
I think PKD1 overlaps with TSC2. They are called contiguous,
TSC2, yes,
contiguous gene syndrome.
Yes,
I mean, yes, contiguous gene syndrome. Then, any other? Would you look into the ADTKD chromosomes? What are the genes that you look for in ADTKD?
Euromodulin,
Euromodulin.
then MUC1, MUC1, REN.
REN? This,
there
you know
is-
theory, but you know where are they located and which genes and which chromosomes?
No, ma'am.
How will you treat this patient? How are you going to follow up this patient now? Besides you're treating it urinary tract infection and looking for reversibility.
Ma'am, if at all it is reversible, after this admission, we will follow up the patient with routine kidney function tests. Or else if she's dialysis dependent, then we will counsel her for long-term access. and renal transplantation.
Go ahead, renal transplant, anything? Which kind of patients? Again, because we are not sure of the cystic disease. So we have to be a little careful with her, no?
Yes.
Then, regular follow-ups. How common is malignancy in ADPKD kidneys? Is it commoner than the general population kidneys, or in ADPKD there will be a higher risk of or a higher incidence of neoplastic transformation of the cysts?
Ma'am,
Ma'am, when you are going to just
incidence
is it common? Is it the same,
it
or
is
is
not
it more?
that common, but
No, same question. Is it as common as general population with kidney disease, kidney malignancies, or is it more than them, or what? How is ADPKD kidneys behave as far as malignant transformation?
Usually there is a late presentation because many of the features of malignancy, they overlap with features of polycystic kidney disease. So patients usually report late or are underdiagnosed.
And the first question, epidemiologically, autosomal polycystic kidney disease confers you a risk of excess malignancy, kidney malignancies. Yes, no?
Ma'am, almost the same risk as usual.
Yes, no, it doesn't. But the malignancies are different. How are they different? Because late presentation, metastatic, multicentric, sarcomatoid changes. So they have a lot of, when they come, they are very aggressive and usually
later
metastatic.
presentation,
But
yes.
it's not more. So this patient, if let's say she improved and gone home, how will you follow her up? Would you still get an MRI this time done?
Yes, ma'am.
Yes. You would, no?
Yes.
And follow up with an MRI for cyst progression or with a CT?
For ma'am, we can monitor with ultrasound.
अल्ट्रासाउंड में तो कुछ नहीं मिल रहा है तुम्हारा 13 सेंटीमीटर ही है ना तुम्हारा किडनी और इतने छोटे छोटे you have said 4.5 mm, it becomes 6 mm, we don't even know whether it's a observer difference or a, isn't it? Some more questions.
Any of the third years around here?
Yeah.
No? All are for exam?
कुछ बताओ, you want to give your opinions? Any one of you want to say something?
Anybody wants to say something
Yeah.
in the case so far? Feel free.
Anything, what do you think do you think this is what your experience with polycystic kidney disease is? How many of you see polycystic kidney disease? In your which year? Second year or first years? Second years, no? How many polycystic, which hospital? How many polycystics you see?
4, 5 at least we've seen, and they've come with recurrent cyst hemorrhages actually, multiple admissions with hematuria. It subsides in 3 to 4 days with conservative management, and then.
How do you make a diagnosis of cyst hemorrhage?
Ma'am, either with CT with contrast, if the patient is on dialysis, otherwise no contrast. Otherwise, MRI we can do with cyst hemorrhage. Or in examination, urinary like hematuria, pain, flash pain.
She said dragging pain, early satiety, all of them have you noticed?
Ma'am, actually we have had patients come with acute.
Have you seen ascites, abdominal distension in some ADPKDs? Anybody?
Not ascites, but abdominal fluid.
So
Some of us have seen because of butt carry. The kidney presses on the liver, hepatic veins. So that is also possible, but that's very rare.
A few other things you need to keep in mind. You may or may not have pus cells in the urine. She
Yes.
mentioned 10 to 12. PKD cyst infection could very well be localized. So all these are very just clinical things that you should definitely know when you're at the bedside. Not having pus cells or a negative urine culture shouldn't throw off your diagnosis of a cyst infection.
True.
Then you mentioned cyst hemorrhage, cyst rupture, kidney stones. What kind of kidney stones do you see in PKD?
Uric acid.
Yeah, so predominantly uric acid, and then remaining are calcium oxide. Almost a half of them could be uric acid stones. This is about this patient. Let us suppose you were the doctor, the nephrologist the patient was referred to back in 2017 when the create was 2. What all would you have kept in your mind for managing this patient? You can be quick like tuck, I want to do this.
The patient has come to you with creatinine 2. The cyst we don't know at the time.
Because you were the doctor, the nephrologist who was actually, the patient was referred to back in 2017. See, now you have like a CKD 5D kidney, we can debate on the diagnosis, the etiology, but at that time, your management is going to make a difference in the course of this patient, in the life of this patient. So what all would you do back in 2017 when this patient had a creat of 2?
Sir, urine routine to look for proteinuria and any RBCs or any casts, then urine albumin quantification, ultrasound of course to look for the size of the kidneys, and then if normal corticomedullary differentiation, we could go ahead with biopsy back then.
Okay, so you can say number 1, I'll treat the hypertension if she's hypertensive. Number 2, I'll treat the proteinuria. How do you treat proteinuria? Either ways or in this patient?
RAS inhibitors we will start for.
So ASARB. These are all treatment goals. You're not going to see like ADPKD, just classical textbook all the time, cyst infection, rupture. People are going to come to you in the OPD with a lot of ultrasounds done outside where they showed cystic kidney disease and they just come to your OPD. Oh doc, I've been told to see a kidney doctor. That's the reason I'm here in your OPD. So at that time you have to evaluate all this. You need to see what's the BP, you need to see if this protein. So you're going to use ASARB. Once you have maxed out ASARB, what agent do you use next in 2025 for managing a CKD patient with proteinuria, diabetic or non-diabetic?
SGLT2 inhibitors.
What do you think about SGLT in PKD?
She just walked into the trap. No. What is the problem with SGLT2 in ADPKD?
You mentioned I'll treat proteinuria. You've started them on an ASARB. Next drug is SGLT2. What do you think about that?
SGLT2 inhibitors theoretically increase vasopressin levels, so that could.
No, not theoretically. Is it indicated? And what is the recent literature to say with the SGLT2 and
Ma'am,
ADPKD?
the trials have been ongoing. There was a recent trial in 2020, which was published recently.
Will you give it or will you not give it?
Considering the literature as of now, I won't prefer to give.
I think we'll hold it.
We'll hold it like that. That's what the examiner will want. But things may change over the next 6
The
months.
first rule is first do no harm.
Yes.
I mean, not necessary.
And why will you hold it?
Ma'am,
You were
because
saying it right, yeah.
vasopressin and
Vasopressin and
increases
something
growth.
else? It will increase the risk of infections also, no?
Yes, ma'am. Increase risk of
Same question again. Would you be using the PHIs in ADPKD?
No, again, they have potential to increase the cyst
Why?
growth because the cyst lining of these patients, they have HIF receptors, which when given, if PHI inhibitors, when they given, will increase the cyst growth.
Yeah.
So now,
Again, just managing this patient, you'll treat the hypertension, you treat the proteinuria. What else? You can be faster. What else what advice would you give this patient?
To manage proteinuria and hypertension, salt
We are over
restriction,
that.
dietary
Number
lifestyle
three.
changes.
Number 3.
What is lifestyle changes?
The salt reduction, weight reduction. If patient is obese, then adequate stopping smoking,
What about
alcohol.
water intake? That's the next
that's
question.
what we want to listen in PKD.
What about water intake?
As far as PKD is concerned, we advise the patient to increase the water intake
To
Why?
decrease the
Yes.
vasopressin levels.
Yes.
What is like, will you just tell them, okay, increase your water intake? You'll have to say something, right?
Sir, more than 2 to 2.5 liter per day we advise, and
Would you be able to, in your clinical practice, will you really call back the patient and check something whether they are taking water properly or not?
urine
तुमने बोल दिया,
osmolality we will
much more
monitor.
easier than a urine osmolality. What can you do?
Urine much more than easier than.
Very simple, which you will be testing regularly. Look at the urine specific gravity and say ki whether the patient is drinking water enough to maximally dilute your urine. That's what you need to do.
Right.
And is that important when you start therapy also? Would you be offering some treatment to creatinine?
That is the next thing we want to
Yeah.
listen. That's why I'm saying
That's why we
keep
are going,
keep
because we wanted to get you a
we're
complete
like,
comprehensive
it's running out
idea.
on time. Like, but if you're
So what is
managing
it?
this
After
patient,
this two
Vasopressin receptor
creatinine.
antagonists.
Huh?
We can vasopressin receptor antagonist if we are not able to achieve adequate
V2 receptor, not vasopressin, V2 receptor
receptor.
antagonist.
specifically.
So what drugs?
Tolvaptan.
How do you decide which patients will need tolvaptan?
Patients who are having EGFR more than 25 with the high rapid progressors.
How do you decide that this patient is rapidly progressive?
With the Mayo imaging classification.
Mayo, what is that imaging classification? Are they different from type 1 cysts and type 2 cysts? You know what is type 1 cyst? What are the types of type
On
1
Mayo
cysts?
imaging classification, which is run on MRI, type 1 and type 2 cysts are there. Type 1 is typical ADPKD, where
That's okay.
there is
Atypical we will discuss later. So which are the ones where you will be, type 1 is divided A to E, no? Which are the ones which will benefit most with tolvaptan therapy?
type C to E.
Yes. So that is something you have to know. And how are they based this classification, type A, B, C, D, E?
On height and age adjusted total kidney volume they have divided.
Perfect. So that is one of the things. What else?
Which we want. What else?
See, everybody is not going to walk in with an MRI, or some people may not do it. The worst is only the good institutes, the radiologist is primed to give you a
TKV
report
also.
like that.
So we
Even though it is as simple as length into breadth into height, but yet you're not going to get the answer unless you talk to your radiologist. 90% of the times you're not going to get a TKV answer.
We don't. We have got some. My students have got some 5-6 ADPK. I don't think we have never discussed TKV with any one of them. Once we did.
So again, you see patient Vaptan. What all do you think?
So we will also look for EGFR trend over if the patient has recent creatinine
Objective.
values.
More than 3 ml per minute fall in 1 year.
1 year.
Kidney size 16.5.
0.5 centimeter.
Make sure you said already the GFR is above 25.
Yes, she said that.
Less than 55 age group. Then
18
strong
to 55 maybe.
18 to 55, yet not approved for pediatrics.
Yes.
Strong family history. If you have nothing but like a rough kidney size of more than 16.5. These are all the things you can just pick up on the history and a quick exam. And then Mayo staging, of course,
That is
objective.
advanced. But first he said strong family history, kidney size more than 16.5, adult, GFR more than 25, and a decline over 3 ml
Per minute per year.
per minute per year.
These answers you're going to have just by talking to the patient and an ultrasound and a KFT, a trend of KFTs.
This is what we would want you from. Then comes the Mayo Clinic and all those things. Is it?
Because on the bedside or in the clinic, that's you need to have your things clear, what all you're going to look for. Only then you're going to able to decide whether do I Vaptan this patient or not. Because
and ensure that urine is maximally dilute.
You know the doses, the side effects, what you do when you suppose we decided to start giving her Vaptan back in 2017. How would you do it?
So we'll start with the lowest possible dose first. The one that is advised is 45 and 15. 45 in morning and
Okay,
15
perfect.
in
45 and
evening.
15. Next, what is the maximal dose you go to?
90 and 30. 120 we give.
What do you
maximum
check?
per
How
day.
often?
1 weekly we monitor, and 1 weekly increment and decrement we can do.
No. What are you checking for when you start tolvaptan?
LFTs we monitor initially monthly we monitor for 18 months and later on 3 monthly, but if patient is tolerating we can increase the dose 1 weekly to 90 milligram and 30 milligram maximal dose, and if LFTs they are 3 times the upper limit of normal, we have to stop tolvaptan.
Okay, so you've mixed it up a little when you're checking the LFTs. I'm just asking all this because these are hard laid out guidelines. This is not a subjective thing. LFT is 0, 2 and 4 weeks, so thrice in the first month, and then monthly till 18 months.
18 months.
That's what the guidelines say. If you're
She said weekly, but she didn't say till 1 month.
0, 2 and 4, thrice in the first month, and then monthly till 18 months, and then after that, like you said, every third month you can do it. So, and again, hard stop is if it's more than 3 times the upper limit, you just stop it completely. In the twice range, you still have to kind of evaluate, decrease the dose, hold temporarily, those things.
Yes.
Okay.
Any other
Anything
drugs?
else? Any other thoughts from you, sir?
Ma'am, most of the drugs they have
Not
proven to
available.
be
Octreotide is I think available, but we don't use it.
Not for
Uska is not
weekly,
even
yeah.
accepted. So I think okay.
think
Thank
we're
you
good.
very much. But be clinical. Now, all of you, please, the request from this year, I know we'll come only once in 6 months, but be very clinical. Very clinical.
And I think when you're telling the story, make sure you're trying to paint a picture for someone who doesn't know the patient. So for the exam trick, either paint it towards what you've read or what you strongly think, or if you're like really taking it clinically, then make sure you're presenting the pertinent positives and negatives. Because from your story, honestly, it was a little, kind of jumbled up in places. We did not get a clear thought. And then a lot of things didn't fit into the case. So again, you'll be off tracked into the Viva for like a variety of questions, and then
don't worry about creatinines. You just have to tell us, look into it and see whether it fits in the natural history of the disease that you're thinking of. The moment it doesn't fit in, don't be very dogmatic about your answers. ADPKD, I think this will fit in, inherited or something like that.
And then biopsies in cystic diseases is very rare. I don't know how often. I don't have any statistics.
I think it's not an absolute contraindication, but
it's very rare. Even if you had hematuria or proteinuria or pyuria, all of this inactive sediment can still occur with, if this was PKD, they can have hematuria with a small cyst rupture here and there. They may or may not have pyuria. Proteinuria will happen as the disease progresses. So none of them is like a hard indicator to biopsy someone and take so much risk. Okay?
Thank you.
All right. Thank you.
Thank you.